And Professor William Novick from the United States. His topic is 30-year experience in assisting in the development of pediatric services, identifying factors for success and failure. Professor William Novick, you have the floor. Thank you for your effort to be with us. You have the floor.
Well, thank you very much. Thank you very much. Unfortunately, I'm sorry that I can't be there live with you. This is the second year that you've invited me, and some disaster has befallen me so that I couldn't attend. But I'm glad to be able to join by Zoom. I'm going to spend a little time today talking about our 30-year experience in assisting in the development of pediatric cardiac services in low and middle income countries and identifying, I hope, the factors for both success and for potential failure. I think a little background history. As a congenital heart fellow at the University of Alabama with a trip to Bogota, Colombia. I went as a solo surgeon and spent time operating 1 week in 2 different institutions in Bogota, whose pediatric cardiac surgeons had just returned to Bogota from the University of Alabama training program. I would say that this experience on this first trip really infected me with the desire to provide services to children in low and middle income countries. I wasn't sure how I was going to do that yet, but I knew I wanted to. In 1993, after I'd graduated out of the congenital program in Birmingham, we made our first team trip to Zagreb, Croatia. Croatia had undergone a civil war, separating itself from Yugoslavia, and previously all of the Croatian kids had been sent to Belgrade in Serbia. So this was no longer a possibility for them, and we were asked to come and spend 2 weeks, if possible, with them, operating on children, teaching, and providing experience. In 1994, at the request of Medtronic, actually, because they had provided substantial donations to me to make trips between 93 and 94, we established the International Children's Heart Foundation, which was a 501c3 registered with the Internal Revenue Service here in the United States. In 1999, I was fortunate to receive an endowed professorship in international child health. And in 2001, this professorship became fully funded. And as a result of that, I was able to fully devote all my time to the development of pediatric cardiac care programs in low and middle income countries. I ceased operating in the United States in mid-July of 2001, once the professorship and endowment fund had become fully funded. As a result of this, by 2005, we were actually making routinely more than 12 trips per year. At this point, we had a full-time ICU nurse practitioner. We had a full-time perfusionist. We had a full-time operating room nurse, and a full-time intensivist. These individuals' salaries were covered by the foundation, and they made every trip that was possible for us. By 2007, 2008, we were up to 20 trips per year. And then in 2014, the clinical staff decided that we should separate from the International Children's Heart Foundation in order to be able to operate on children of all religious entities. And we established the William Novick Global Cardiac Alliance in late October of 2014. This is a little bit of the historical perspective that will bring you up to exactly when the Novic Cardiac Alliance was founded. Now, our assistance model is the following. We'll receive a request for assistance, and it can come from a physician, pediatric cardiologist, adult cardiac surgeon. It may be an institutional request. The administration of the hospital may have decided that they would like to expand or implement a pediatric cardiac program, or may come even higher than that. We've been asked by multiple ministries of health to establish programs in their country. And on two occasions, we've been asked by either president or vice president of a country to help them improve pediatric cardiac care in their country. Regardless of the nature of the request, we make a virtual site visit, either through Microsoft Teams or Zoom, et cetera, any of the multiple possibilities. And we usually spend 2 or 3 hours on that initial virtual site visit, talking to all of the stakeholders, and if possible, and Wi-Fi connect adequate, they'll actually take us on a tour, a virtual tour, excuse me, of the hospital. If after that conversation exists, then we would travel to the requesting site and spend 2 to 4 days making an on-the-ground site assessment, talking to all the shareholders, really inventorying all equipment, understanding the local need in terms of potential number of patients that would need surgery, and determining whether or not there are other competitive programs in the region which might prevent this particular program from developing. If that assessment is positive, then it's necessary for us to secure funding. Once we've done an inventory on this physical site visit, we may notice equipment deficits. We've been very fortunate to receive a large number of cardiopulmonary bypass machines, ventilators, monitors, heater coolers, occasionally even echo machines. And if any of those things are necessary to fill equipment deficits, then we will have our biomedical engineers make sure that all of that equipment is functional when it departs the United States, and we'll ship it to the site. Once that has arrived, we actually schedule a team trip, and the members of the team are vary in number depending upon the local infrastructure of the institution that we're assisting. So it may be we only take one surgeon, one anesthesiologist, one perfusionist, one OR nurse, but it's also possible that we may take 2 of each of those individuals. Obviously, intensivists, 2 or 3 are necessary. Pediatric cardiac intensive care unit nurse educator, ICU nurses, respiratory therapists, pediatric cardiologists, and then depending on what we've noticed on our previous physical site visit, we may bring a biomed duration, typically from 2 to 6 weeks. Yes, in some sites, we're there for 6 weeks continuously. And visits are typically 3 to 6 per year. And the purpose of multiple years and multiple visits is to do a stepwise graduated program in experience, education, and skills. And we believe that it is necessary for the program to receive multiple visits by us during the course of the year so that they are able to advance their experience and their capabilities. And hopefully, after through 2, 3, or 4 years, depending upon what level of complexity of operations they want to perform and what weight they would like to work their way down to in terms of children they operate on. If you're looking for a program that has started from zero and would like to be able to perform neonatal intracardiac surgery, I can tell you, I don't believe we've ever established a program from zero to that level, neonatal cardiac surgery, in less than 4 years. Now, let me give you a little bit of brief overview of our effort to date from 93 as International Children's Heart Foundation until 2014 as Novak Cardiac Alliance. And actually, this information is about as up to date as it can be because I spoke to the team that's in Misrata, Libya, about 30 minutes ago. Between 1993 and 2023, 36 countries have received assistance to us. Now, not all of these 36 countries have had continued assistance because even though we may find that there's a particular site that fulfills all the criteria we think, the first visit is the real test of whether or not you're going to be able to develop a program there. So we have actually curtailed efforts after less than 4 trips in 7 different countries, which brings us down to really somewhere in the neighborhood of 28 to 29 countries that have continued to receive assistance for multiple years. 60 different institutions were visited in these 36 countries, and a total of 391 trips were made as the International Children's Heart Foundation, and 166 trips to date made as the Novak Cardiac Alliance. The total operations as of as of 7 p.m. 6 p.m. Misrata, Libya time is 1,160 children. There are currently 29 programs that have graduated from our assistance program and are performing operations independently without our assistance. Now, I'm not going to say that we don't occasionally make a trip to one of the graduate programs. We believe in maintaining our relationships with all of these places. And we may make one trip to Beijing every 2 years or one trip to Macedonia a year or something like that. But there are 29 independent programs, and those independent programs in aggregate are now performing 10,000 operations per year. It took us 30 years to reach 10,000. But along the way, we helped enough programs where now those programs altogether are operating on 10,000 children annually. Now, this is a very interesting slide, and it's the management of complex change and how to approach it. This is a slide that we're going to talk about where failure occurs. So if you will look at the very top of this slide, you will see vision, skills, incentives, resources, and action plan. If all of those lead successfully to the next step, then you can expect change to occur, whether it is in the establishment of a pediatric cardiac surgical program or improvement in a pediatric cardiac surgical program at a particular institution. Now, where things start to break down is on the next line. And as you'll see, vision doesn't exist. There's not an overall plan of where this program is headed. You may have skills. You may have established incentives for your staff. Your resources may be adequate, both from the point of view of government funding and materials. And you have a plan on, how to operate each day. And it sort of just bumps along. There's confusion about where this plan is headed. So you lose your vision. And in the end, you may not make the progress that you wish you had wanted. Now, the next one down, obviously, is a very interesting situation where you have the vision and everybody buys into the vision of developing a pediatric cardiac care program. But you find out that the skill level of the particular healthcare professionals that need to deliver the technical skills is inadequate. Now, we've run into this problem in 2 or 3 places around the world where a particular surgeon and or cardiologist may be touted by the Ministry of Health or the hospital administration as being the future star of the program, only to find out that the surgeon's incapable of actually opening a sternum in the midline, even after 2 years and 4 trips each year of training. The pediatric cardiologist cannot perform adequate hemodynamic cath, for instance, for a MAPCA search or for provocative pulmonary hypertension cath. And so basically, you're now left with that breakdown, then there's a lot of anxiety, there's a lot of never ever off the ground. So human and the hospital's ability not have the skill level necessary, and we need to add another individual. That's very important. If the hospital is not going to back your concept and your idea and your evaluation of the breakdown in individual skill levels, then there's no point in continuing your program. And we've had this occur, as I mentioned, in a couple of places. If you're missing the incentives, now the incentives come in a number of areas. Incentives may be providing conference attendance for your medical staff and nursing staff once a year, rotating individuals to different conferences. It may be financial if they work overtime. But if you don't have incentives for your people and you're working them too hard, then their motivation to develop the program becomes lacking. And as a result, the change that you get over time is extremely gradual. And quite frankly, in what could be developed in 2 to 3 years may now take 4 to 5 years. The absence of resources is devastating to the development of a program. We have seen this in a number of countries where the Ministry of Health will be providing necessary supplies for 3 months. And when those supplies are gone, you're having to wait for another 2 to 3 months for replenishment of supplies. And this is an extremely frustrating situation and has led a number of individuals that we have dealt with over the years to simply walk away because they don't feel they have adequate support from the government to provide the resources necessary to care for these children and to develop a program that the country would be proud of. And then lastly, no action plan. So you have everything. You have the vision, the skills, the incentive, the resources, but you're not sure exactly how to start it. And I would say it has been our experience that it's best when programs want to achieve independence if during the intervals between our visits, which could be anywhere from 3 to 6 visits a year, we're able to assess an increase in the number of cases they're doing without our assistance, in a flattening or even decrease in mortality in the cases they're performing without us being there, and with a decrease in weight for children that are undergoing total correction. It's, I think, imperative that as a visiting program that is trying to improve or start pediatric heart surgery, that you have a local database that is routinely kept and that is routinely reviewed, and they actually send you reports of what they're doing in between your visits. We request this from all of our programs, and we also request that all of our programs that would have any issue with a clinical decision, with a diagnostic dilemma, can contact any of our four surgeons and review cases with them, send them images, etc. So we don't want a program to have false starts, have high mortality, and become frustrated and stop and start and stop and start. So establishing a good line of communication with the program, keeping up with the results that the program has in between your visits, I think they're very important for program development. Now, this article is actually written by Dr. Durrani out of Mayo Clinic, and you can find it in the Seminars in Thoracic and Cardiovascular Surgery, Pediatric Cardiac Surgical Annals in 2010. And I still think this diagnostic approach is cogent to the development of pediatric cardiac programs requesting assistance. With regards to the database that I was speaking about, with regards to diagnostic dilemmas, et cetera, we're sincere and committed believers in quality assurance and improvement. We encourage all of our sites to enroll in an International Quality Improvement Collaborative in congenital heart surgery and cardiac care. As many of you may, and some of you may actually be enrolled in the IQIC. This was established in 2007 as a result of multiple biannual discussions at the Global Forum for Humanitarian Cardiology and Cardiac Surgery, which is held in Geneva beginning in 2001. We discussed the differences in results between high-income countries that have been practicing pediatric cardiac care for 50, 60 years and low and middle income countries who were just initiating a program or had only been performing pediatric cardiac surgical at a simple level for 3 or 4 years. We did not believe that it was appropriate to compare the results of low and middle income countries with relatively limited experience to those of high income countries. This resulted in the development of the International Quality Improvement Collaborative. We also believe, and there's a database, a REDCap database that you sign into from the cloud and upload your results to the cloud. Twice a year, they provide you with an anonymized comparison of your program versus the other 65 programs or so around the world that are enrolled in IQIC. But I think it's also important to establish an in-house database, and we'll get a little bit more into this a little bit later on this slide. This allows you to keep up, I think, really contemporaneously with your results, to spot problems early before they become embedded and consistent. We encourage all of our programs to have a computerized in-house database that is maintained in a contemporaneous fashion. We believe that you should initiate a monthly quality improvement, quality assurance conference involving all the departments that are involved in the care of children with heart disease that end up going to surgery or to the cath lab for an interventional procedure. If you have your in-house database for both the surgical component, the intensive care unit component, and potentially for the interventional cardiology component, you can bring up issues that have occurred in the previous month in this QA conference. It is really important in these conferences. We all used to call them morbidity and mortality conferences, but it's really important in these conferences to identify system failures and to not finger point at individual caregiver failures, at least within the confines of the conference itself. If you have discovered that a particular individual seems to have a recurring problem, then obviously the head of that department needs to speak to that person individually in confidence. Now, if you have an in-house database, you can establish locally driven clinical and translational research projects. And this is actually one of the incentivizers for people maintaining their motivation. If you'll look at a number of our publications over the years, you will see that whenever we work with somebody to develop a research project with them, we don't walk away with the data and publish it or present it without all of our colleagues at the particular sites that have been involved being co-authors or at times presenters of the particular research project that we're talking about. You need to establish some form of continuing medical and nursing education programs, and they should probably be on a monthly basis. Whether this is a journal club, whether this is a nurse educator, establishing a program to discuss specific topics like infection control. All of that's decided locally. But just establishing continuing medical and nursing education programs is critical to maintaining the integrity of your program. It's really important for you to provide quarterly reports both to your regional and national health ministries. This is something which will benefit you in the future. When they know that you're a program, that you're expanding a program, that you're improving results, and you're caring for children with congenital heart disease. We've found that in a number of the different countries that we've traveled to, that the either regional or national Ministry of Health has no real understanding of the magnitude of congenital heart disease and its impact on the finances of the healthcare ministry in the absence of having corrective surgery or interventional cardiology. So this is a form of advocacy for your institution to advocate for federal assistance or regional healthcare assistance by showing them the magnitude of the problem on a regular basis, quarterly. And then you have to think about the future a little bit. And so we like to involve the medical schools and nursing schools that are close to the city or the institution that we're providing assistance in so that they can rotate through on a regular basis and become, a little bit exposed to the complexity of pediatric cardiac care. And hopefully you will engender in them an interest in continuing down that pathway so that you don't run into the problem of having your surgeon age and retire and nobody to back him up. Or the same for anything else, anesthesia, intensive care, perfusions, ICU head nurses, ICU nurse educators that you've developed. So getting medical and nursing students involved before they move into their residency or clinical rotations for nurses, may provide you with people that now become interested and want to continue on in developing their skills, their experience, and their education in pediatric cardiac care, and can become the future of your program. Now, these are just a few things that I think are pathways to successful program independence. You've got to have a motivated staff who all understand what the overall vision is. Where is it we want to go? And how do we get there? Human resources are absolutely critical, and I'm sure all of you know that. We all suffer with a shortage in different countries of nursing staff or perfusionists or anesthesiologists. Anesthesiologists seem to be like diamonds, hard to find. We believe you should progress carefully in increasing the complexity of the operations performed in our absence and decreasing the weight of children receiving total corrections. High mortality is a destroyer of programs, not only for the hospital, but for the parents that lose those children, for the backing of the Ministry of Health, and for the community and society in general. And that's why we really think it's critical for you to develop your program in a stepwise fashion, to review your results, to know what the issues are, use your QA, QI conferences to correct those problems, and go step by step in the development of. You cannot go from doing ASDs and VSDs on 10-kilo kids at the end of the year and expect to be able to do neonatal arterial switches with a 5% mortality. That's just not going to happen. You should develop a synergistic relationship with the hospital administration. It's absolutely critical that the hospital administration have a complete philosophical and potentially financial backing of the pediatric cardiac care program, because the hospital administration can also be your advocates with the Ministry of Health. And that's why the next point is that you need to develop a close relationship with the healthcare ministry by providing them with the quarterly reports that I mentioned earlier. Every country that we go to, we try to encourage individuals that have a high level of motivation to get a group of people together and to establish a charity which is registered in the country, which may be separate from the hospital or with the hospital. This allows you to develop corporate, civic, private, and religious entity donors. And that's an important additive amount of financial assistance during times when the country's fiscal budget will not allow for adequate funding for the number of children that you know you need to care for. So if you've established a charity which has been able to grow and is provided with interval updates through newsletters or meetings with the board of directors, you can develop a great relationship and a source of funding in times of low federal or regional healthcare funding. We think that one of the most difficult things to do is to develop routine funding from the federal government in a number of the countries that we go to. In those countries where we have been successful in developing government funding, literally we may have developed 2 or 3 programs in the same country. Iraq is a very good example of that. We've developed in Karbala, Najaf, Nasiriyah, and we're currently trying to develop a program in the deep south in Basra. But none of this would have been possible without government funding, because the magnitude of the work that's been done in Iraq. We've operated on over 1,400 children in Iraq in these 4 different sites that I mentioned. And 3 of the 4 sites are now independently operating, and 1 performs quite good neonatal cardiac surgery and is actually the only neonatal program in the entire country. You need to nurture a positive relationship with the media. Awareness of your program. The media can provide you with opportunity to find new donors. But this is a double-edged sword here again. And so you need to have someone who's facile in working with the media in order to maintain excellence in that relationship. Well, this is really my short, I think, 30-year history. And I close with these two children. The child on the left in a reposed position is a post-op day 1 tetralogy of Fallot, operated on in Lubumbashi, Democratic Republic of Congo, earlier this year. He became a team favorite, quite frankly. The team really loved this kid. On the right, you will see the first successful arterial switch performed in Rwanda, in Kigali, at the King Faisal Hospital, and that was also done earlier this year. There are now, I think, 4 or 5 of these children that have been done with our assistance, and they've all been successful. But that program is very unique. The lead surgeon was trained in Melbourne, spent 2 years in Addis Ababa operating, and decided to move to Rwanda and brought a number of his team members from Addis with him. So this was not a typical startup program. This is a program where there were experienced individuals, and the request that they made from us was to help them move into cardiac surgery. And so that's what one trip there this year. We'll be making another trip a little bit, 2 trips, another trip in late February of next year, and then again in July, and probably a third trip in November. So success is possible, but failure exists around every corner. And vigilance within the results of your program, within the motivation of the individuals that are staffing your program, vigilance in keeping all of that together is what leads to success. I thank you, and I'm happy to answer any questions that you might have.